good morning, afternoon, or evening, whichever applies regarding where you are geographically or whenever is applicable pertaining to when you watch this presentation/episode. My name is Dr. Joshua John Curry. I am a licensed, board certified, doctoral level alcohol and drug counselor. I am the founder, president, and chief clinical director of multisystemic programming for Dr. Curry and Associates. Welcome to this presentation, which is the first episode of the How to Place Active Addiction Behind You podcast. The title of this podcast mentioned placing active addiction behind you rather than defeating active addiction. I went this route as far as the title because I wanted there to be comprehension of the realization that sustained active recovery will be an ongoing battle. And here's where I'm going with that. I've met people personally as well as professionally who were blessed to accumulate 5, 10, 15, 20 plus, 30 plus years of not only sobriety or abstinence, but sustained active recovery. But I've learned through personal experiences, whether directly or indirectly, professional experiences, whether directly or indirectly, that we are all, regardless of where we're at, pertaining to our path towards sustained active recovery, we're all one triggering antecedent, one bout of emotional dysregulation or psychological imbalancing. We're essentially all one bad day away of having that lapse or that relapse, in which could result in us plummeting back into the unfortunate period of active addiction. This is one thing as far as this particular podcast and this platform that I've decided to create. Initially, I wanted this to be just a one-time presentation. It was going to be approximately 90 minutes, 2 hours, or 3 hours, whichever in the end would have been the time result. But upon going through some editing, I came to the realization that rather than this being a one-time extensive presentation, I should just convert this into a podcast. And this is something that's going to be ongoing, just like treatment, just like rehabilitative treatment at the outpatient setting. Let's just say hypothetically, we have a client, we have someone, they've reached that point in which they came to the realization that, okay, I do need help. Matters have become unmanageable for me. So they go through detoxification or withdrawal management programming, followed by a period of inpatient / residential treatment lasting 90, 180, or perhaps even longer days as far as duration. They transition into intensive outpatient programming. They complete that, they step down to outpatient programming. Now that we've reached that particular level of care, I've been asked professionally, I've been asked during family criminal courts, I've been asked by loved ones, I've been asked by individuals, how long will I be in an outpatient setting? And this is where matters become distinguishing, because this could come to an end for you in 12 months, 15 months, 18 months, depending on what's taking place as far as socioeconomically, sociologically, psychiatrically, geographically. There are a lot of considerations that we must take into consideration as far as how long treatment could be on the outpatient setting. I've worked with clients throughout the years in which we've worked together for 2 years. They've moved on and lived great lives as far as progressing towards sustained active recovery. I've worked with people during my career in which they've been in treatment longer than I've been alive. And at the time of this recording, I am 38 years old. I've worked with people who've been in treatment for longer than 40 years, and they're still presenting with various forms of severe clinical diagnoses as far as specification goes. So that's what I was speaking of along the lines of we're all ultimately one bad day away from experiencing or positioning, from getting ourselves positioned to experience that lapse that could transition into a relapse that ultimately could result in us plummeting back into active addiction. So this is what I wanted to treat this podcast as if I'm working with a client individually. And my intentions are to have varying updates on a consistent basis as if I'm working with a client individually. And hopefully the information that I have during this episode and subsequent episodes could be utilized to ultimately help someone out in their life to help someone during their struggles with active addiction to help them move towards sustained active recovery. From a terminological standpoint, I will predominantly address substance abuse or chemical abuse throughout this presentation, as well as during subsequent episodes. Despite that, I would like for you all, the audience, to understand that gambling-related considerations, sexual concerns from an addictive perspective, such as finding oneself habitually consumed by watching pornographic programming, excessive video gaming, and other addictive-related complications are applicable with the subject matter of this presentation and also with future episodes that's going to correlate with this podcast. Before I transition to the first subtopic, I have intentions on addressing, and I would like to offer one pro-social coping skill anyone could utilize if and when they find themselves overwhelmed by a triggering antecedent and is potentially getting positioned to engage in some form of chemical abuse, which could be that lapse, that transition into that relapse that puts us in a position to fall back into or plummet back into active addiction. One thing that I've used throughout my career is I've used this one particular coping skill, and I do have intentions on throughout this recording, throughout this episode, and throughout subsequent episodes and presentations. I do have intentions on presenting an array of coping and replacement skills. It may not be applicable, it isn't universal. It may not be a one-size-fits-all approach, but this could be something that could be very advantageous for a large amount of people. One particular coping skill that I've at least made recommendations that I've offered for, as far as in clinical settings during individual, group, or family counseling sessions, I would ask a client, I said, how would you feel about making a list? In this particular list, I always go with, let's make a number, 1 through 10. Let's number this list 1 through 10. So what we're doing here is you're having a rough day. You're having a rough bout. Circumstances are getting dire for you. And we are at least experiencing those cognitions and those feelings. We're going through or we're enduring some form of emotional or psychological dysregulation. We're thinking about reaching out, making that antisocial notification. Ultimately, we're thinking about diving back into some form of, whether it be experimentation or recreational substance abuse. Now, before we do that, I like to offer to put this into our coping and replacement skill tool bag, so to speak. We're going to make that list. We're going to number it 1 through 10. What we're doing here is we're documenting 10 things. And of course, I always offer, or at least I always like to encourage clients, if you can go more than 10, that's even better. But I at least like to, let's just focus on 10 at a minimum. The point is, what we're doing here is we're listing at least 10 things, whether it be the near future or distant future, that we would like to see ourselves from a realistic perspective. And what I do here is I implement what's referred to as SMART goals, which is an acronym for specific, measurable, attainable, relevant, and time-bound. So we're looking to list at least 10 short-term or long-term goals that we realistically see ourselves accomplishing at some point in the near or distant future. My intention here is, whenever I'm offering this recommendation, what I'm doing here is I want us to at least hopefully transition our thoughts, transition our feelings, transition our psychiatric concentration, what we're focusing on that's troubling us, that's triggering that emotional dysregulation, that's potentially positioning us to engage in some form of substance abuse. I want to take our minds off of that and put it onto these things that we see ourselves accomplish, whether it be completing high school, attending college, perhaps joining one of the 5 branches of the armed forces, possibly watching one of our children achieve something athletically or academically. We're talking about starting a career, getting ourselves perhaps into some form of vocational skill training to even get ourselves employed. Matters along those lines. Get ourselves, if we're involved with the Child Protective Services or the criminal justice system, what we're doing here is we're making that list, finalize involvement, fulfill all engagements, all obligations with those entities, just to get that form of distress off of our plate, so to speak, theoretically. So what we're doing here is we're making that list. And whenever we find ourselves dysregulated or imbalanced psychologically in the future, which will happen because we are human and we do have terrific days and we do experience some not so great days. This is just a part of being a human being. What I'm doing here is I want us all to be proactively prepared for when we have these bad days. We're going to grab that list again. We're going to review that list when another bad day presents itself. We're going to review that list. And what we're going to do is the purpose of that is to get us back in a happy frame of mind, so to speak, to get us back grounded, to get us back to a point of regulation where we can function emotionally, we can function psychologically or psychiatrically. So we already have those 10 things documented. What we're doing here is we're going to go from 1 through 10. Now we're starting a new list, 11 through 20. Now the rule that I at least like to offer, let's do the best that we can to not replicate anything. And that rule is ever. So the further we go along, as we go from 21 to 30, 31 to 40, so on and so forth, now we're putting down a lot of things that we see ourselves accomplishing. Again, these are specific, measurable, attainable, relevant, and time-bound. These are SMART goals, the acronym for SMART. These are SMART goals. So as that list grows, and it continuously grows, we're adding to that list from an ongoing basis. The purpose there is to get ourselves to a sense of well-being in which we're not overwhelmed or dysregulated or imbalanced so habitually that we're not adding to that particular list. And again, this is just one of many pro-social coping and replacement skills that I at least like to offer and recommend to clients. And like I mentioned, all we can do is work collectively as a practitioner working with clients. All we can do is put our heads together, work collaboratively. And it is very important, whether you're a practitioner or whether you're a client, it is very important to make sure that this particular dynamic, that this form of documentation is collective, it is collaborative. Because what we're doing as a practitioner, we're just offering recommendations based off of either contemporary clinical research, through studies, or perhaps even if you are in active recovery yourself, if you've decided to give back and work in the field, or you just feel as though this has been something that you've been drawn to, such as myself. You feel as though this is one of the reasons why you were put here. This is one of the gifts that you can offer society. This is one of the gifts that you can offer humanity. One of the things that you're good at. So now you're in a position to give back to or help others, regardless of where you're at, or if you're a client. What we're doing here is we're working together. It's very important for us all to work together, because from the client standpoint, it is ultimately that person who's struggling with active addiction. It is ultimately up to him or her. It is ultimately up to them to incorporate into their lives, between those individual, group, or family counseling sessions, in between those periodic, if this is applicable, in between those telephonic notifications or whatever form of communicative notifications that are allowed to transpire. It is up to the client. It is up to the consumer, to that person battling active addiction, seeking to progress towards sustained active recovery. It is ultimately up to them to implement or incorporate what's recommended during these gatherings, during these times together. So that's one of the things that's just one of many, like I mentioned, pro-social coping and replacement skills that I like to at least offer to clients. I haven't had anyone say that this isn't something that they would not be willing to do. It's at least something that we can try. Perhaps it's something that could be advantageous for one. Perhaps it's not something that may not work for another. But this is reasoning behind why whenever I'm working with a client and I'm putting together some form of rehabilitative programmatic treatment planning, this is why I, at least whenever I address coping and replacement skills, and I do the best that I can to, and of course, if this is what the client wants, I do the best that I can to at least put out there that we should look into, or we at least should consider adding pro-social coping and replacement skills with corresponding interventions such as individual psychology, cognitive behavioral therapy, solution-focused brief therapy, psychoeducation, whichever is applicable under those circumstances. Let's identify that correlating intervention and add to treatment planning, and let's utilize what's recommended or what's depicted during that treatment plan or in that treatment plan. Let's utilize that programmatically during clinical sessions and also between clinical sessions. Now, this is where I would like to transition into the first subtopic of this episode, which is symbiotism. Symbiotism, a symbiote is an organism that attaches itself to the host and it takes over its host. Symbiotism, whenever I work with a client initially, and of course, throughout our duration together, I make certain that one of the first things that I address is symbiotism. What I'm doing here is I'm leaning upon psychoeducation. I'm bringing an understanding to the neurological transformations that we go through during our struggles with active addiction. Here, I want to use a little bit of visual aiding. What we have here is the human brain. What we have here is a symbiote. At this time, they're not unified. During chemical abuse, during active addiction, that symbiote essentially attaches itself to the host. And during active addiction, from a neurological standpoint, during substance abuse period, transmitters, neurotransmitters, and other entities of the human brain go through unfortunate antisocial modifications. That's a form of symbiotism. That symbiote has now attached itself to its host. It will now take over that host. It will now put ourselves in a position in which we're engaging in activities. If we're in our right minds, if we're not under the influence of any form of mind-altering chemical, we wouldn't even imagine doing such things. One particular thing that I like to highlight when I'm addressing symbiotism, when I'm utilizing symbiotism from a psychoeducational standpoint, I'll ask a client, have there ever been times in which perhaps you've raided the medicine cabinet or whatever applies of a loved one? Where I'm going here is particularly an elderly loved one who perhaps need these medications, these prescription medications for their well-being perspective, for their morbidity perspective, essentially to stay alive. We know here is, or if the client isn't aware of what I do here is, I make certain that the client understands. And at this point, we're early in our active recovery. At this point, I'm talking about we're going through some sort of withdrawal symptomatology or whatever is applicable, and we're just seeking. That symbiote is calling us. That symbiote is saying it's time to take care of matters. And what I'm talking about here is substance abuse. So at this point, we're struggling financially. So we don't have the funds to go out there and purchase what it is that we're seeking to purchase. But that physiological, that psychological, and perhaps even depending on the chemical or chemical grouping, that physical anguish that we're going through, it's not getting any better. So now we're reaching a point of desperation. This is where we go over to grandmother's home. We know grandmother perhaps isn't as mobile as she once was. Perhaps her vision is impaired slightly. Perhaps there's some form of audio deficiency. Perhaps grandmother isn't able to hear as well as she used to. So we know that we could not only enter grandmother's home, but we can go into grandmother's bathroom or wherever she keeps her medication supply. We can take those medications. If these are medications that we're in a position to abuse, now we're in a position to take care of that. If not, now we're going out, we're engaging with antisocial entities or affiliates, and we're exchanging grandmother's medications for chemicals for us to abuse, just to experience some form of euphoric dissociation. What happens here is that symbiote. Now, of course, we love grandmother, and we would never do anything to intentionally harm grandmother. What that symbiote does, that symbiote is essentially blocking all of those cognitions, all of that sense of well-being as far as decision-making, thinking rationally. That symbiote saying, yes, we have grandmother here, but we're not going to worry about her right now. We have to take care of ourselves, and we have to get these chemicals. So that means raiding grandmother's medication cabinet, then so be it. The unfortunate thing there is now grandmother must ultimately pay for those misappropriations. And here's what takes place. Let's just say hypothetically, and this has and does happen very frequently as far as the world of active addiction. Let's say grandmother just got those medications refilled and she was giving a 90-day supply as far as her refill. Now, grandmother is 3 days into a 90-day supply. So what's happening here is grandmother's going to get her medication. Her medication's gone. Grandmother, of course, is going to call her medication prescriber. The medication prescriber, with varying programs that's taking place to combat active addiction from an epidemic standpoint, unfortunately, these notifications are probably going to fall on deaf ears, so to speak. Now, these are human beings that are being called. Grandmother's will call her medication prescriber, hypothetically, of course. But in most cases, this is what will take place. The prescriber will let grandmother know that they will reach out to the pharmacy. So now the pharmacy, of course, they feel badly, but they see this very often. That's just reality. The pharmacy knows how this is going to go. They will let grandmother or whomever know that they will reach out to the insurance provider to request some form of early authorization. The pharmacy representative is more than likely aware of how this is going to go from an outcome standpoint. The authorization will probably not go through. The insurance company or representative will let the pharmacy know that, unfortunately, we will not be able, at the earliest, that we can even allow this authorization to go through would be perhaps in another, and just saying hypothetically, another 45 days at the earliest. And this reasoning for this is because of, unfortunately, there was a period of time in which people were shopping around pharmacies, hospitals, and other medical entities. They were shopping around, getting their hands on prescription medications, perhaps exaggerating what's taking place as far as ailments. They were accumulating very expeditiously. They were accumulating prescription medications for abuse purposes rather than to treat medical concerns or challenges. So unfortunately, in the medical field, these measures or these barriers were implemented. And who had to suffer was that innocent grandmother, who all she did was allow her grandson or granddaughter into her home, figuring that their loved one was just coming over to see them, to see how they're doing, to spend time with them, to just share some time with them, to talk with them, to bond with them, and things along those lines. Not even realizing, or perhaps even knowing, just from that wisdom as far as the family dynamic, but perhaps just hoping, perhaps just even praying that their grandson or granddaughter was not coming over to raid their medicine cabinet. Perhaps they were aware that there was a small chance that this could take place, but they were just hoping that their intuition was incorrect, only to find out that they were fortunately victimized in some manner. And under those circumstances, what I do as far as in a clinical setting, I like to remind us that if this were to happen, we are essentially committing crimes. Whether we're talking about larceny offenses, related offenses, whether we're talking about some form of possession, whatever's appropriate as far as jurisdictional or from a terminology standpoint, we are essentially committing crimes, and we could face, depending on the nature and the severity of what's accumulated and the details corresponding with those particular actions, we could face significant months in county jail, or perhaps even years in state or even some form of federal correctional facility. So under these circumstances, I bring my knowledge of the criminal justice system to my drug and alcohol practices or my co-occurring practices. And I like to make certain that we're not ignoring that some of the engagements that we're involved in while we're supporting active addiction, despite us not being wholeheartedly aware of what's taking place, despite going back to symbiotism, despite that symbiote controlling our rationalization, our justification, our decision-making. When we're facing a criminal court judge, it's not about symbiotism, unfortunately. Even if that person was slightly or perhaps even vaguely aware of what they were involved in, what will more than likely happen, that criminal court judge will say that regardless of any experts that were called upon, and may do the best they could to intellectualize dissociation, depersonalization, derealization. Despite those efforts, that judge will say, okay, and even with substance use disorders ultimately being mental health disorders, according to the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, the judge will say, you were involved, you were not forced, or you did not go through any form of entrapment in which you were essentially forced by someone else. You were not, those circumstances doesn't exist, or they did not exist. Despite your clinical illnesses, you introduced those mind-altering chemicals into your system. And I'm just paraphrasing what I've heard judges mention on many occasions. The judge will say, yes, Dr. such and such or expert such and such may have done an excellent job explaining concepts corresponding with symbiotism, pulsation, conditioning, which I will not address during this episode, but I will address those particular matters that correlates with substance abuse. This is relatively more contemporary, newer research as far as pulsation. That judge may say, the expert did a great job intellectualizing and explaining pulsation to us, conditioning to us, symbiotism to us. But the judges, I've heard judges say, and again, I'm just paraphrasing, I've heard judges say, rather than you reaching out to a clinical practitioner, rather than you reaching out to sponsorship, or rather than you just getting yourself checked into a hospital to help with detoxification or withdrawal management programming, you made the decision. You were not in a trance. You made the decision to go to your grandmother's home and unfortunately steal her medication, and she had to suffer and go through various forms of, despite any iatrogenic dependence that she may have developed from this medication management programming, you put your grandmother in a position in which her health and overall well-being was jeopardized. So what I'm going to do for you, sir or ma'am, I will remand you to XYZ correctional facility. You will serve XYZ period of time incarcerated. And unfortunately, one thing that I've made efforts to do is get various entities throughout the Department of Corrections, statewide and nationally. I do live and work in Southwestern Pennsylvania. I'm doing the best that I can, and this is going to be a methodical, gradual, ongoing process. I want to make certain that correctional facilities are sufficiently equipped to handle not only substance use related issues, but also potentially co-occurring mental health related issues as well. And I will dive into that. I will spend time with this particular podcast. I will spend significant time addressing co-occurring considerations as far as substance abuse as well as mental health. So those are matters that when I meet a client, those are matters that not only that I like to dive into initially, addressing that and correlating that with what we can do to put active addiction behind us. Just like I mentioned, this is something that could be ongoing with me knowing, like I mentioned during the commencement of this episode, I spoke of knowing people personally and professionally whom were very successful as far as their progression towards sustained active recovery as far as 5+, 10+, 20+, 30+ years of sustained active recovery, only to unfortunately have those very bad days in which they found themselves plummeted back into active addiction. But these are matters that I will periodically just focus predominantly, whether it be 60, 75, 90 minutes during individual counseling sessions. These are matters that I will periodically come back to, regardless of where someone is, as far as the theoretical stages of change, as far as where they are regarding their path towards sustained active recovery. I just want to make sure that we're not disregarding some of those matters that took place. I just want to make sure that we're not going through any form of compartmentalization. So just in case we are having those bad days, I want to make certain that we're reminded of how dire things could be, not just for ourselves, but for our loved ones. And this is where I would like to transition into blueprinting. And blueprinting, just like in If we're thinking about engineering, designing some form of horizontal structuring, we're not just going to get ourselves to a work site and start hammering away, drilling away in matters of those lines. We're going to get some form of blueprinting together. We're going to get a game plan together. So I like to use that same approach, and I utilize blueprinting through treatment planning, working with the client from going back to that collaborative approach. What I do here is we're going to use that treatment plan as a blueprint. We're going to highlight every diagnosis, whether we're talking about a primary, a secondary, tertiary, supplementary, or other, or perhaps even an unknown. We're going to get every diagnosis listed. We're going to get those prioritized, understanding that these are fluid. We're going to address cross addiction. What I mean by cross addiction is that we have our struggles with, we'll say hypothetically, with the abuse of synthetic cannabinoids, but we're also battling the abuse of hallucinogens, whether those are classic or dissociative hallucinogens. We're also diving into the abuse of alcohol. So what I'm doing here is, regardless of where those chemicals or chemical groupings lie, as far as being a primary, secondary, tertiary, supplementary, other, or perhaps even unknown diagnosis, I want to get them all listed. I want to have those all depicted throughout treatment planning. And also we're addressing any form of co-occurring mental health considerations, such as a persistent depressive disorder diagnosis, a generalized anxiety disorder with panic attacks diagnosis, a post-traumatic stress disorder related diagnosis. I want to get all of those added to treatment planning, understanding that diagnoses can be fluid as far as their severity, going into early remission, sustained remission, and matters along those lines. I just want to make sure that we're addressing those. And going back to blueprinting, we're also diving into and designing and implementing applicable SMART goals, going back to those specific, measurable, attainable, relevant, time-bound goals. We're identifying other matters that could jeopardize and also perhaps aid our progression away from active addiction towards sustained active recovery. So as we're going through blueprinting, as we're putting these blueprints together through rehabilitative programmatic treatment planning, what I'm doing here is also addressing matters that may not perhaps be applicable to treatment planning, but they are extremely relevant as far as our well-being and life outside of a treatment facility. What I'm talking about here is, what can we do to put ourselves into position to say to ourselves, substance abuse, whether experimental or recreational, substance abuse just is not worth it any longer. What I've endured, I've had enough. I have no desires. I have no desire, no aspirations to re-experience anything that corresponds with active addiction. So what I'm doing here is I'm identifying, okay, what can we do? Can we return to school to finish that high school diploma? Regardless of how intimidating those measures can be, let's do it. So I'll be asked, Dr. Curry, what if I fail the examinations? No big deal. What I do here is I utilize motivational enhancement therapy. I say, you do have the intangibles. You do have those highlight affirmations. I'll share with the client something that perhaps they've told me that I didn't know, or they've introduced me into something. One thing that I've had introduced to me was this equation as far as active recovery. Abstinence plus change equals active recovery. So we have that sobriety. I didn't get that from undergraduate, graduate, or postgraduate school. I've never heard that when I was going through my own bouts of rehabilitative treatment. Someone mentioned this during a group counseling session I was facilitating deep into my professional career. This gentleman, very intelligent gentleman, he mentioned that it's not about the abstinence, it's about making those positive, pro-social, cognitive behavioral modifications. We couple that with abstinence, and that's how we move towards sustained active recovery. And I'm always very excited to, during my time working with this gentleman, I'm always very excited to highlight how I took what he shared during that group counseling session, and I've used with others who perhaps weren't there. I've used with others who perhaps were not listening during that time, and even meeting with him, running across him and other loved ones when we did separate, as far as him moving on from the facility, moving on with his life. I'll share with him that I've told that formula, I've utilized it in so many different ways. I've facilitated educational blocks of instruction with practitioners in the field, and I've utilized that one thing that I learned from him, not from a colleague or not from a professional setting or someone facilitating some form of workshop that I was a part of. So matters along those lines, I will highlight to a client that I've taken stuff from you and I've used, not just for one client, not just for one male, not just for one female. I've used something or things that you've told me, whether it be some form of psychoeducational material, whether it be resources. You've helped me help others. You've helped me help myself, whether it be personally or professionally. Not too long ago, I've worked with a young lady. I'm still working with her. She had shared with me something. She knows I'm a parent. I'm a very proud parent. In my office, there are quite a few pictures of my loved ones, of myself, my wife, and our two children. She had shared with me something with, we have, as far as our oldest children, they're relatively close in age. And we were talking about parenting. That particular individual counseling session, it focused on parenting. And she had shared with me that she had a dream about being a parent of an adolescent or a young man or a young woman, of a teenager, whichever applies. She shared with me that as parents, it's very instrumental for us to, of course, we have the we're the end all be all as far as decisions that are made. But she shared that it is very important for us as parents to take that step back and recognize that our children, regardless of their age, they have their own perspectives, their own standpoints, their own emotions, their own views on things, their own thoughts and feelings. And that's something that we may know as human beings, we're aware of as parents, but we may not always have that from a decompartmentalization standpoint. That may be something that's always in the back of our minds, or at least for myself. And when she said that, that was very powerful. And ever since then, whenever I'm engaging with either of my children, I do, at the time of this recording, I do have a 4-year-old son, and I do have a daughter who's on the verge of being just a few days away from her 14th birthday. So essentially, I have a 14-year-old daughter and a 4-year-old son at the time of this recording. So whenever I'm engaging with either one of them, regardless of what's going on, I'm always cognizant of course, as their father, I am the end all be all. But it is very important for me to at least listen to them and take the step back and, okay, implement in whatever decision I'm going to make, implement their respective thoughts, their feelings, and things along those lines. So those are just a few examples in which I've used whenever someone going back into blueprinting. And what can we do to get ourselves confident to move towards adding to that respective blueprint so we can progress further away from active addiction towards sustained active recovery. So whenever that client, whenever I'll just say hypothetically, let's go back and complete high school. And a client will share with me that he or she's been out of school for well over a decade and a half. And even during the time in which they were in school, attendance was horrible. It was very inconsistent. There were a lot of suspensions. They were expelled multiple times. There were an array of transfers and things along those lines. And matters were not exactly essential as far as making certain that they were set up to be successful academically. So what I'll do here is, in addition to utilizing motivational and enhancement therapy and identifying those affirmations a client could at least, I'm not saying that what I'm going to say or recommend or offer or suggest is going to put them in a position to leave my office or in our time through teleconferencing or whichever is applicable during that time. I'm not expecting that whatever is going to be offered or thrown from me towards the client is going to put the client in a position to be wholeheartedly confident in themselves as far as moving towards the accomplishment of that objective. What I'm doing there is I just want to plant that seed essentially. I want to add that supportive beam to their foundation so they can at least become somewhat, or at least a little more gradually confident in themselves so they can achieve that goal. And that's what I was diving into a few moments ago, talking about what if we do fail that examination? No big deal. I want to use that examination failure. Let's not look at it as failure. Yes, let's utilize that as a learning opportunity. What can we do better? Let's identify what happened. Let's identify what was supposed to happen. We were supposed to pass that examination. Okay, what did happen? I struggled with this subject. I struggled with those subjects. Okay, when can I retake the examination? Whether it's 30 days, 90 days, 180 days, whichever applies. Let's identify, okay, what are we going to do to make certain that we are at least a little more successful the next time around? So what we're doing here is, this is where I transition from motivational enhancement therapy. I move into solution-focused brief therapy. Okay, so if we do fail the exam, or we did fail the examination, where were we weak at? First of all, where were we strong at? Let's focus on the positives. I like to lead with what I like to refer to as a positive sandwich. What did we do well? Okay, we were strong here. We were strong there. What I want to do here, I want to continue with reinforcing those strengths, but also we don't want to spend more time on the strengths and ignore those weaknesses. Let's continue with reinforcing those strengths, building upon those strengths, but where were we weak at? What are we going to do realistically? Going back to those SMART goals: specific, measurable, attainable, relevant, time-bound. Realistically, what are we going to do as far as focusing on our academic / educational / intellectual areas of weakness? Could we allocate just 1 hour out of the day, whether that be waking up earlier, cutting back on our breaks, whether that be lunch break, our smoke breaks, whatever applies, whether that be, I'm a movie watcher myself. I like to take time throughout each day just to watch, whether it be a classic or some form of newer movie. I do like to watch movies, but okay, at least now I'm trying to go back to high school to finish that high school level of education. So I have this examination in my way. Is this something I can go without? We have to identify, where can I get an hour from? Or even if that includes going to sleep a little later, where can I get that hour from? So once we identify that, now we have to be disciplined, because Dr. Curry won't be there. Perhaps even others in your life whom are positive influences, they won't be there to hold your hand theoretically or to force you. This is something that's going to have to be internalized. Are you going to dedicate, hypothetically, from 6 o'clock p.m. until 7 o'clock p.m. just hitting the study material for 90 days consecutively? No breaks, no justifications, no rationalizations. No matter what, I'm going to do this. And if the answer is yes, we can move on. We can add that into our blueprinting. If that's not applicable, one thing I like to also offer as far as adding to blueprinting, and the whole point of this, just to remind you as the audience, the whole point of, again, whether you're a practitioner and you're working with clients, or you're someone yourself who came to that realization, you reached that point and said, no more as far as active addiction. I am ready to move towards sustained active recovery. What can I do? I like to identify employment. Employment is something, whether we're working 4 hours a day, 6 hours daily, 8 hours a day, 10 hours a day, depending upon the profession and the organization. We have to keep in mind that the amount of time we spend actually on the clock, we spend more time geared towards or allocated towards our the fulfillment of our occupational obligations. So here's where I'm going at. We have to get ourselves prepared as far as getting dressed. We have to make certain that we have our meals and other materials packed so we can get through that day, get through each day. There's transportation, whether you're walking, whether you're jogging, you're utilizing some form of a bicycle, public transportation or an automobile, there's time. There's time allocated unless you're in a position to work remotely. There's time allocated towards traveling to, not just to, but also from work. When you return home at the end of the day or the next day, if you're hypothetically working as a in security or in corrections where you're working overnight, whenever you get home, the remainder part or the next chapter of that respective day doesn't start immediately just because you walk in the door. There's still some form of recuperation or recovery from your workday. So all of that is time. The whole idea of mentioning this is we're getting ourselves in the position to take away that downtime, going back into symbiotism. If we're not employed or we're not engaged in something that's positive, that's pro-social, if we have an immense amount of time throughout each day, if we're just sitting there with nothing to do, we're not accountable to anyone or to anything, that symbiote is going to say to us, hey, you have nothing to do. I have an idea. How about we make that call? I was told that, and this is the symbiote talking, that symbiote is going to say, hey, I was told that barbiturates are being mixed with opioids. That's a peculiar combination. How about we try that out? You've not been into the abuse of barbiturates or opioids ever in life during your X amount of years or decades in active addiction. How about we go try something new? And what we're doing there is we could say to ourselves, we could say to the symbiote, that's not for me, that's not my thing. But before you know it, because you're not accountable, because you have nothing to do later in the evening, you have nothing to do tomorrow. Again, you're not accountable to anyone or anything. Before we know it, we found ourselves in a location geographically in which we probably shouldn't have been. So even though we've told ourselves that I'm not going to experiment with the abuse of barbiturates being mixed with opioids and some form of unknown chemical compound has just been created, I'm not going to go through that. But before you know it, you're now in a position to get your hands on it. You're in a geographical location. You're within that proximity to get your hands on this. So now what I'm doing here is, now we're talking about potential polysubstance abuse, or we're speaking of someone presenting with features of what's referred to as an other or unknown substance use disorder related diagnosis, because with these chemical compound modifications, contaminations, and matters along those lines, what are we abusing? Are we abusing what comes together when we take a barbiturate and an opioid? We combine those together. Is that substance an opioid now? Is it a barbiturate? We have no idea what it is from a chemical compound standpoint. We're talking about how much of each has come together. We're talking about how these chemicals came together and possible modifications from a chemical compounding scientific standpoint that could have or may not have taken place. So all of these matters we're introducing into our bodies. So what I'm doing here is I'm talking to a client and I'm saying, if this is you, how are our bodies handling it? Your central nervous system, your brain, your heart, kidneys, pancreas. I'm just listing very essential body parts. How will those body parts react to you either reintroducing or initially introducing this chemical or these chemicals into your body? How will you react? Of course, we're excluding suicidal ideations, at least during this episode. We're talking about the intentions of just experiencing some form of perhaps newer, more amplified intoxication, inebriation, dissociation, depersonalization, derealization. We just wanted to get separated from reality. But what if our vital organs, or what if some part of our body doesn't react in that particular manner? Now we're going through some form of adverse reaction where hospitalization is needed, where emergency responders are needed immediately. We're not in a position to notify emergency responders on our own because we're experiencing some form of dissociation, separation from reality. So now we're essentially dependent upon others around us, Will they notify emergency responders immediately? Perhaps, maybe not. While they're figuring out, okay, how can I get in trouble? We're possibly breathing our last breaths. So I like to present these hypothetical scenarios in which, in a lot of cases, unfortunately, throughout my career, I've had clients say back to me whenever I'm saying this same thing. I've had clients say back to me, I've actually experienced that. I've experienced that multiple times. And I'll ask the client, were you attempting to harm yourself? Were you attempting to kill yourself? Most of the time, the answer is no. I was not attempting to harm myself. I was just looking into, and I'm just paraphrasing from an immense variety of clients I have going on in my head right now as far as responses. Just paraphrasing all of these collective responses. The client is just sharing that I just wanted to endure some form of inebriation, some form of separation from reality. That is it. And before you know it, I was hospitalized. I woke up, I came back into reality, and I was connected to a bunch of machines. So at least fortunately, I was able to walk away. So what takes place here is this is where I'll transition into, let's just say emergency responders didn't make it in time. Because when we're under these circumstances, we don't have a lot of time on our hands. We may not have hours, we may only have minutes. Now we have to think about traffic. We have to think about geographical locations. What I'm talking about here is there was a time in which during my career, I worked in a rural area. There was a lot of substance abuse. This was a residential facility. There was a lot of substance abuse taking place in that rural area. I've spent a few winters in that rural area, and very seldom were the roads plowed when there were blizzards and snowstorms. Even a small accumulation of a wintry mix could result in the roads being in a place in which they're not able to be traveled upon. Just because that geographical area, they didn't not only plow the roads, they didn't treat the roads at all. They didn't salt the roads, which is something that's definitely needed where I live and work in southwestern Pennsylvania. But living in this rural area, and we were only a few miles, we were only less than 10 miles away from the nearest hospitals. But 10 miles, when the roads are very bad, could be virtually impossible to travel. And there was a time in which there was a resident whom I was working with. There was a resident who found themselves experiencing some form of adverse reaction. We did reach out to emergency responders. Unfortunately, they were not able to make it. Helicopters, they were occupied during that evening. And this evening transitioned into earlier in the morning. We were told that there's going to be about an hour wait as far as helicopters. We didn't have the appropriate vehicles to travel, and this was a very bad ice storm. But myself and a counterpart of mine, we did the best that we could, and we navigated that road. It took us approximately 2 hours to travel less than 10 miles to the hospital. Luckily, the young man was able to get treatment, and he was okay. But things could have gotten a lot worse. And I shared with them that what we were told as far as emergency responders, the ambulances in the local area, they were not able to travel. The roads were just that bad. Luckily, we just had one vehicle that happened to have been used during vocational programming. It was modified in a way that at least allowed us to travel on the road. Myself, one reason why I was at the facility, and this was relatively late in the evening, the roads are very bad. I was stuck at work. So I just, my intentions were to sleep there, but I spent the entire evening in the hospital with the young man, but luckily he was okay. But I'll use stories like that, and I'll make certain that whomever I'm speaking with, whether it be a practitioner, whether it be a client in a one-on-one setting or a group setting or a family setting or a setting such as this, I'm speaking to an audience by way of the internet. I make certain that there's an understanding that this is not an incident that was made up. I am not that creative. This isn't something that I saw theatrically, whether on a movie or news broadcasting or some form of television broadcasting. This was something that I experienced professionally. So what I'm doing here is I'm putting clients in the position to say, what if we go through this form of experimental recreational form of substance abuse, and we have that adverse reaction, and you're not able to make it as far as emergency responders. So what's going to take place? You pass away. How will your loved ones feel? How will your children feel? How will your close friends feel? Matters along those lines. So what I'll do there, I'll ask that question. If this is a person whom I've worked with extensively, so of course, this will enable me to identify names and certain people, close relationships, centers of influence, matters along those lines. I'll say, how would your son feel if you were to pass away, your oldest son? How would he feel? Very often, I know that's a very tough question to ask someone, but anyone who's worked with me, they know where I'm getting at. I want us to get in a position in which we're constantly thinking from a cognitive behavioral standpoint. And I'll sit back, I'll ask that question. How would your oldest son feel if you experience some form of adverse reaction to some chemical? And nowadays, we have no idea what these chemicals are or these chemical groupings. You think you're getting an opioid, you're getting an amphetamine. You think you're getting a cannabinoid, you're getting a hallucinogen. You think you're getting this, come to find out it was that. It's been modified. So how would your oldest son feel? And very, very frequently, I'll be told that my son, and I'm just paraphrasing, my son will be good. He'll be living with such and such family member, the loved one, the husband is a paralegal, the mother is a social worker. They're very religious. They're into church. They're into family activities. It matters along those lines. They're into birthdays, Christmases, holidays, vacations, and all those wonderful things. And I said, okay, that sounds like a very, very fun, very fruitful childhood. But despite all of those things, despite having two professionals in the home, despite having a very strong male and female role models in the household, despite vacations, private school attendances, tutoring, being set up for success. How would your son, and I'm not talking about that. I'm not talking about brand new clothing or sneakers for back to school. I'm not talking about having an immense amount of gifts under the Christmas tree that Santa Claus made certain that your son had. I'm not talking about that. I'm not talking about having a brand new automobile, which I've been told during your son's 16th birthday. I'm not talking about that. I'm talking about emotionally. I'm talking about psychologically. I'm addressing psychiatric considerations. That's what I'm speaking of. How will your son feel? And this is where, when I say that, I'll tell the client, and I'll say, please do not say that because I've met your son. I know that you and your son have a very strong, unconditional emotional bond. You guys love each other unconditionally. I know that. I've seen it. I've seen it on many different occasions across multiple settings. So how will your son feel? How will your son manage emotionally or psychologically? Not just that you passed away, but you passed away because of some form of overdose or chemical poisoning. Now how will your son feel? And as I'm asking that question, I'm presenting to you as the audience. I don't have many responses that are coming back to me now. This is normally where a client will say something vague, or we'll find ourselves changing the direction of the individual counseling session. But this is where I bring it back. I'll say that let's not ignore that if we can. I know it's tough. This is where those tears will start to come because now we're thinking, and that's the whole point of it. And people who work with me, they understand that my intentions, of course, I never want to upset anyone. I want you to have a great day. I want you, whether you're coming to see me physically or you're logging on to some form of teleconferencing, I want you to have a great day. I want us to have a positive, productive individual or group or family counseling session together. And I want you to leave and continue having a wonderful day. But I feel as though that I do owe you, because you're giving me that privilege to not only work with you, but to work with your loved ones. So I feel as though that I owe you to make certain that I'm not just looking at that clock to hit that 60, 75, 90, whatever's applicable, whatever's appropriate, not to make certain that I hit that mark. I feel like I owe you to make sure that we're in a position to think about something that either has not been addressed before or to make certain that some form of compartmentalization has not taken place. And I want to make certain that we're keeping things at the front of our mind as far as how dire things could be as far as active addiction if we were to return to any form of active addiction, experimental, recreational substance abuse. Because unfortunately, it's not just the euphoric dissociation, intoxication, inebriation that we have to be concerned about. We should also focus on those extremely negative consequences. And I'm not talking about a brief period of involvement with Child Protective Services. I'm not addressing a couple of weeks or a couple of months or whatever's appropriate as far as being incarcerated. I'm talking about something that could last not only a lifetime, but generationally, as far as your child who unfortunately went to your funeral because of some form of adverse reaction triggered by an overdose or chemical poisoning. How will that child bear with their children emotionally, psychologically, psychiatrically? What form of manifestation could take place as far as their children? So now we're talking about generational implications. We're talking about what happened here as far as your overdose impacting matters from a genealogical, generational standpoint. So these are amongst many of an assortment of things that I do have intentions on covering during this podcast, on the episodes of this particular podcast. I really feel as though that there's not much out there as far as clinical contemporary information that people could easily access. This is why I at least wanted to do my part, not just to work with those whom I encounter in southwestern Pennsylvania. I would hope that the information that and the research that I would do and the personalized experiences that I've had as far as with myself personally, not just personally, but professionally, I hope that this is something that could be easily accessed to someone nationally or perhaps even internationally with language considerations being taken into place. I just want to do what I can to create this podcast. My intentions are to have each episode be at least 60 minutes long. I want to treat each episode as though this is an individual counseling session. Now, of course, no one's speaking back to me directly, but I did want to create this particular platform. I'm definitely encouraging us to leave comments, to share your perspectives, share your experiences, because myself as Dr. Curry, with active addiction being so broad, such a broad spectrum, whether we're talking about prevention, addiction, intervention, and recovery, it's very broad. And Dr. Curry is very confident, as I am in my abilities professionally. I do not have all the answers, but like I mentioned, the few clients whom I've worked with that I've shared during this hour-long episode during this podcast, I've shared that I've learned quite a bit from clients whom I've encountered. I've learned, of course, from my colleagues professionally, and I'm never shy about mentioning that I've learned this from somewhere else that ties into epistemology. You know, how knowledge is amassed, how it's sustained, and matters along those lines. So please feel free, whether it be this episode, check out others that I do have intentions on getting one uploaded at least once weekly. I will have new content, and of course, there will be times in which, just like I mentioned, I'm going to treat this as if it's rehabilitative treatment planning, an individual counseling session, and matters along those lines. I will build upon this particular foundation while also periodically going back and addressing matters that were discussed previously. That will conclude this presentation / episode. I genuinely hope you found the information informative and that either you or someone you know could benefit from this platform. If so, think about liking and sharing this video. If you have not already done so, look into subscribing to our YouTube channel, which is Dr. Joshua John Curry, EDD, and hit that notification bell so you can be notified when videos and presentations have been uploaded. In addition to this presentation / episode, we have multi-systemic presentations that our organization put together and upload to YouTube. Those respective presentations are predominantly psychoeducational, talking about prevention, addiction, intervention, and recovery. Also co-occurring mental health considerations, the criminal justice system, child protective services, and matters along those lines. And we do have those presentations uploaded at least weekly. There's also a parenting-related podcast that I have. It's referred to as the Dr. and Mrs. Curry Parenting-Related Matters podcast. I do have that with, like I just mentioned, Mrs. Curry, my wife, located on our channel. Whenever you have time, visit our website, which is www.drcurryandassociates.com, which will connect you to our company, which is Dr. Curry and Associates. Look into viewing and following us on Twitter. Our Twitter handle is at Dr. Joshua Curry. Like I mentioned, I am very passionate about this movement towards, from a sociological standpoint, I'm very passionate about this movement towards putting active addiction behind us. Like I mentioned at the onset of this episode, I didn't say win the fight against active addiction or win the battle, because like I shared, this is something that essentially is going to be a lifetime for us. We can go 5 plus, 10 plus, like I've mentioned throughout this podcast, throughout this episode, 20 plus, 30 plus years, and things are great. But before you know it, boom, we've had employment terminated effective immediately. Someone is sick. We're sick. Someone passed away. We were given a terminal prognosis. So now we're thinking about what can happen as far as dysregulation or imbalancing. We're all one antecedent, one circumstance away from possibly experiencing that lapse. And that lapse doesn't have to be a one-time incident. It could be one time. It could last 3 days. It could be a 7-day binge. But as far as the differences between a lapse and a relapse, we have that. Let's just say we have a 2-week binge. We have a 2-week methamphetamine-related binge. So we were working towards sustained active recovery. We were in programming. We were meeting with Dr. Curry twice weekly for 75 minutes per individual counseling session. We were very involved with peer support related groups and sponsorship. We were involved with spirituality, volunteering with the church. We were employed. We were involved with, in addition to being employed, we were also involved with vocational training, because we're prioritizing career progression. We want to advance. We were doing all of those wonderful things. The prescription medications that we had for our co-occurring mental health challenges, the bottles or the medication prescriber mentioned, one will be taken every 12 hours. That's what we were doing with meals. That's what we were doing. We were not selling our medications. We were not deviating from that plan. We were not affiliating with any antisocial individuals or groups. We were not frequenting any locations or involved in any activities that could jeopardize our advancement towards sustained active recovery. We were doing everything appropriate, in addition to abstinence, like I mentioned with that formula. Abstinence plus change equals active recovery. We were doing very well, but boom, we just found out a very close loved one received a unfortunate fatal prognosis, and it was estimated by medical professionals that this person had roughly 4 to 6 months to live. So that form of emotional imbalancing or psychological dysregulation put us in a position to have that brief lapse. That lapse, like I mentioned, was hypothetically 2 weeks, and it was methamphetamine related. But during that lapse, we realized that this isn't going to solve anything. So rather than binging and supporting that form of addiction, let's get back on that horse. Let's reach back out to sponsorship. Let's get back involved with spirituality. Let's get back involved with employment, with vocational enhancement. Let's get back involved from a rehabilitative programmatic standpoint. So that's how we stop that lapse from transitioning into a relapse. We stop the antisocial activities that were taking place, and we done something about it from a positive, pro-social, cognitive behavioral standpoint. That lapse turns into a relapse when all of those things that I just mentioned, they don't happen. Then 2 weeks turns into 1 month. 1 month turns into 90 days. 90 days turns into 6 months, into a year. And once we've gotten that deep, obviously, we've now returned to a pattern of cognitive behavioral mannerisms or attributes in which we're synonymous with whom we were during our battles with active addiction, the estrangement. the involvement with criminogenic impulsiveness, the disregarding responsibilities, whether that be employment, our significant others, our children, family, and other obligations and matters that we were accountable for. So now during active addiction, we're no longer accountable to anyone or anything. That symbiote is now taking back over our lives. It's running the show. We're now going back into grandfather's medication cabinet. We're now burglarizing homes. We're engaged with prostitution and matters along those lines just to support active addiction. So these are matters that I do have intentions on addressing during various subsequent episodes of this particular podcast. I am very excited to get this off the ground. I am looking forward to, like I mentioned, I genuinely hope that the information that I had during this hour plus during this episode is something that either you or someone you know or someone you love could at least use. And also consider looking back and looking into returning to the channel and checking out future episodes that I have in association with this podcast. And also, like I mentioned, look into some of the other psychoeducational presentations that my organization had posted, had uploaded to YouTube. And if applicable, if you are a parent or if you are looking to become a parent, if you have the time to do so, check out the Dr. and Mrs. Curry parenting related podcasts. Thank you for taking part in this presentation / episode. I will definitely catch you the next time around.